Yes. So today I will cover tumors of kidney. There are different types of tumors. The basic class is benign and malignant. Tumors of kidney of benign nature, they are not that much important as the malignant types. In benign, this is the adenoma. It is a very innocuous type of tumor. In angioma, it is important because there is chances of hematuria there, because kidney is a vascular organ. Then the third is angiolipoma. Its importance is that there are chances of conversion to a malignant condition. So that is its importance. Now coming to the more important and more common malignant tumors, renal cell carcinoma is the most important. Then UTCC, that is the upper tract transitional cell carcinoma. These two are prevalent in adult persons, and in children it is the Wills tumor or nephroblastoma. Coming to renal cell carcinoma, it arises from renal tubular epithelium. It is among the top 10 commonest cancers. If the death is taken into consideration, it causes 2% of all cancer deaths. Male-female ratio, it is more common in male, about twice as common in female. About 35,000 deaths per year in Europe is caused by this disease. The median age is about 64 years. Now, classification of this renal cell carcinoma. There are many subtypes, but the important subtypes are either this is the clear cell renal cell carcinoma that comprises about 83 to 88%, and the second is non-clear cell carcinoma, and the common of those is papillary RCC and chromophore RCC. Now, what are the risk factors? Age is one. I told you the median age is 64 years. Sex, more common in male. Obesity. Obesity adds to its causation. Then hypertension. The person suffering from hypertension, they have more chances of having this disease. Cigarette smoking is an important factor. Then other medical conditions like chronic renal disease, hemodialysis, if one is on renal transplantation, or acquired cystic diseases of kidney. Then some genetic factors. There is twofold increase if there is a risk. There is a history of family history there. Then chances are twice as common. Then another is BHL, that is born Hippolyndose disease. So these are the risk factors. Now coming to clinical features. The most common triad is loin pain. So the patient feels pain in the same side. There is mass may be there, or hematuria. But this is present in classically 10% cases only. In some there will be pain only or some vague symptom. Many of them may be no symptom there. In most cases, the diagnosis is done following ultrasonography and CT scan of abdomen done for some other diseases. And there is a chance finding. Then paraneoplastic syndrome, there is hypercalcemia, fever, and erythrocytosis. And that draws attention that maybe patient is suffering from RCC. Now, what investigations? You know, I told you about ultrasonography. Here is the commonest that may give a space occupying lesion there, or some changes in the structure of kidney. But CT of abdomen, pelvis, and chest, they are done for assessment of primary tumor as well as regional spread, like lymph node spread, or spread to the metastasis also. MRI gives additional information because it is if there is vascular extension, in that case MRI becomes important. Other investigations, bone scan or PET may be done to assess the staging of the disease. So what is the pathology? If we see by naked eye, the cut surface looks golden yellow in color with hemorrhagic and necrotic area here and there. But microscopic appearance, that is, there are clear cytoplasm arranged in nests or tubules, and these clear cytoplasm is due to accumulation of glycogen and lipid inside the cytoplasm. There are different grading systems. One is Fuhrman grading system. It graded in the 4 nuclear grade, 1 to 4. Then Leibovitz prognostic score. This is also a grading system, but it is important for prognosis of the disease, not for diagnostic purpose. Here is the picture that shows different stages of the disease. One is stage 1. Stage 1 is the disease where there is swelling or there is growth is confined to the kidney. It is less than 7 centimeter. Stage 2 is where it becomes bigger than 7 centimeter, but it is still confined to the kidney. Stage 3 is that where it may go beyond the kidney, or it may even affect the adrenals or other structures. Then stage 4 is where it goes beyond the fossa of Gerota, or if there is vascular involvement. This staging is given in the next slide. You can see these are the staging. Tumor is less than 7 centimeter, but limited to kidney. And stage 2 where the tumor is more than 7 centimeter, but is still limited to kidney. Stage 3 is where tumor has enlarged, but it is not gone beyond the Gerota's fossa, may involve major veins, adrenals, and regional lymph node. And stage 4 is where it has breached the Gerota's fossa and goes for metastasis to the distant organs. How do you treat a case of renal cell carcinoma? Now, surgery depends on clinical stage and general condition of the patient. I told you about the different stages. Nephrectomy. Nephrectomy is a radical nephrectomy or a partial nephrectomy. Now, partial nephrectomy is done for a localized swelling or a curative condition. And here, if you remove that do a partial nephrectomy, the patient should be cured of the disease. Means it is suitable for stage 1, but it is confined, very small and confined to the kidney. It is also suitable for those patients who has not only one kidney, and there you have no option but to do a partial nephrectomy. Partial nephrectomy is also done for those patients where there is bilateral involvement of the disease, or patient has some other conditions. The partial nephrectomy can be done by an open method or laparoscopic method or robotic assisted partial nephrectomy. So these 3 we can do this partial nephrectomy. Then this radical nephrectomy, here not only you remove the kidney, but the fossa, perinephric fat, and also the lymph nodes. That is the radical nephrectomy. Then ablative therapy are those where it is in a higher, much advanced cases, but ablation is done by either using cryotherapy or radiofrequency ablation. It is important because the kidney is a vascular organ, so ablative therapy works here. For medical management, targeted therapy for metastatic RCC, tyrosine kinase inhibitors are used, which are inhibitor to the vascular epithelium growth factor, because it is very vascular organ. So such treatment are important. Sorafenib or sunitinib are the important drugs. The same manner, vascular epithelium growth factors, monoclonal antibodies are also being tried. But their palliative, their supportive treatment, hardly patient go beyond 8 to 9 months on these treatment. Now, another important malignant condition is UTTCC, that is upper urinary tract transitional cell carcinoma. It involves renal, pelvis and ureter. I told you RCC involves the kidney, but here UTTCC involves the pelvis and ureter of the kidney. It may be multifocal. 5 to 10% of all urothelial carcinoma are made by this. The standard treatment for UTTCC is nephroureterectomy. Now, a common condition, common malignant condition, that is Wilms tumor also called nephroblastoma. They arise from embryonic nephrotic tissue. Up to 5 years of children, they are involved, they are affected. Usually one pole of kidney is affected. Clinical features are, they are very rapid growing tumors, and the whole abdomen may be involved. This becomes a big mass of abdomen in the abdomen. Some of the patients may suffer from hypertension. If there is hematuria, it means that the finger is extended to the renal pelvis, so there is bleeding from with the urine. Metastasis is common. The commonest site is lungs, then liver, bone, and brain, and other sites may also be there. For investigation, we can use ultrasonography, CT scan, where space-occupying lesion may be seen in the kidney, the age of the patient, per abdomen and lung, and a space-occupying lesion in kidney will give you diagnosis of Wilms tumor. How to treat such case, chemotherapy is done and followed by nephrectomy, that is the treatment. That's all about tumors of kidney. Thank you.